All right, fantastic. I think I'm just going to get started with a bit of an introduction about who EveryDoctor are, because we need to get started soon, because I know how busy everybody who's attending this is this morning. To introduce myself, my name is Julia. I'm a doctor by background, but I now run EveryDoctor. We are a campaigning organisation led by doctors, and we advocate for NHS patients and staff together. We're extremely concerned at the moment about what is happening, and we have a network of about 400,000 people who we speak to every day in a conversation about what is going on in the NHS and what needs to happen to improve things. Our work is strengthened with a Facebook community of about 25,000 doctors, and many of those doctors feed into our work and inform us about what is happening. We're joined this morning by 3 frontline senior NHS doctors who are going to be explaining what is happening. And the briefing that we're running for you today is called Revive the NHS. We're running this campaign at the moment because things in the NHS are in a really bad state, and we've identified some short-term solutions which can improve things. I'm just going to start with a little bit of housekeeping for those who are in the meeting today. So first of all, when we're not speaking, we're all going to put ourselves on mute just to avoid any background noise interfering with the discussion. And secondly, any questions that you have for us, please pop them into the chat box. We're going to be collating those, and there'll be a question and answer session towards the end where we'll hopefully answer any questions that you might have. Beyond this presentation, if you have further questions, if you would like any help with anything, please feel free to send us an email on campaigns, that's with an S on the end, at everydoctor.org.uk, and we'd be delighted to help you out with any questions you have about the NHS. If we don't know the answer, we will find it for you through our network. And finally, before we get started, I'd just like to say an enormous thank you to everybody who's attending today. We know that one of the ways that we try to encourage people to come to these meetings is through asking constituents to ask their MPs, and sometimes you are bombarded by emails from us. I know from feedback we've had from MPs that sometimes that is uncomfortable, and I'm very sorry about that. But we are really, really grateful for your engagement, and the reason that we do that is because we feel that a lot of politicians aren't taking this situation seriously. That is obviously not a sentiment that we extend to anyone who's attending the meeting today or who has requested the documents. We really, really appreciate your time, particularly today, because we can tell that there is a lot going on in your workplaces in Westminster, and I imagine there are a lot of competing demands upon your time this morning. Okay, so let's get started. We have a 5-point plan to revive the NHS this winter. Hannah, could you click onto the next slide, please? I've kind of talked us through this already, but this 40-minute meeting will be, I'll run a presentation. I'll then be taken over by Dr Megan Smith, who is our head of legal and policy, and she's also an NHS consultant anaesthetist. She'll be talking about the pension situation specifically. We're then going to hear some frontline testimony from 3 senior NHS doctors, and then we'll move on to the question and answer session this morning. Okay, so an overview. I'm sure that this isn't news to you. However, things are getting worse and worse, and I think there has been poor media reporting on this, and so it's difficult to see the trajectory of the situation. We're now at a point in October where every part of the National Health Service is at breaking point. It's really terrifying. Patients are really suffering, and it's impacting them adversely to the point that some patients are now dying because of the situation, and their deaths could be prevented. We're moving into the winter. It's going to be the worst winter on record, we think, for various reasons. This situation is not being tackled by the government, and we see that as a huge failing on their part, and we're really terrified for patients. We have sought advice and input from our network of UK doctors to come up with a plan, a little list of 5 short-term policy measures which could be easily implemented by the government to safeguard things and make it better for patients and staff this winter. In our opinion, this is an emergency situation, and these policy changes need to be made immediately. We cannot wait because every single week that we wait and we do not do anything, patients are dying. This is not a political game. This is a situation where lives are being lost, and it needs to be taken extremely seriously. Could you move to the next slide, please, Hannah? Thank you. Okay, so we're going to focus primarily on the NHS in England during this presentation, because the situation there is worse than it is in other parts of the UK, in the devolved nations. However, there are problems in the other nations of the UK, and we'll touch on them briefly. If you are here as a representative of an area of the UK which is not in England, please feel free to contact us. We will find more relevant information for your patch. It's not good anywhere, but in England it is particularly bad. So at the moment, there are 7 or above 7 million patients waiting on a hospital waiting list for treatment. This is the longest the waiting lists have ever been during the entire NHS history. It's really, really terrifying. And this is a situation affecting so many people. It's putting pressure on every area of the health service. We have situations where GPs are managing an extraordinary clinical burden because a lot of patients are waiting for specialist input in hospitals, which they're not receiving. So the workload for GPs and the stress and the strain upon our primary care services is higher than it has ever been. And this needs to be taken really seriously. We cannot only look at sort of ambulances and A&Es when we think about this situation. However, thinking about the ambulances, that situation is really, really bad. So we've put a couple of statistics here. The ambulances are taking too long to arrive at patients' homes or places when they have health problems, accidents, etc. This is a complex situation. It's multifaceted. Some of it is because they do not have enough staff, and some of it is because if you think about a number of ambulances being on the road and available to pick up unwell patients, if you have 20 ambulances sitting in an A&E car park waiting to offload a patient into an A&E department, those are ambulances which could be on the road picking up patients. There's backlogs at every area of the system. The hospitals are too full and cannot send well patients back into the community because of problems in social care. So there's enormous pressure within the hospital wards. Patients within A&E are struggling to move from A&E onto a ward because of that situation. And then because there are so many people in the A&E department, the ambulances are struggling to offload patients into the A&E. So it's a system-wide problem. And what has happened as a result of that is that there are fewer ambulances circulating, going around and picking up patients, and that is lengthening the time that people are having to wait in order to have an attention from an ambulance. The target for what is called a Category 1 ambulance reporting time is supposed to be 7 minutes. That's the top category. So that is if somebody, for example, was having a cardiac arrest, and you call an emergency ambulance, and an ambulance with a blue siren going around goes to that patient. It should take 7 minutes for that person to receive an ambulance. It's taking an average of 9 minutes, 19 seconds. Now, I know that to people who haven't had experience within the healthcare service, that 2 minutes, 19 seconds might not seem enormous, but in terms of the delivery of immediate healthcare required in those types of emergency situations, those 2 minutes and 19 seconds can be the difference between life and death. It's extremely serious that that has lengthened. There's also, I've put down here, a Category 2 ambulance waiting time. There are actually 4 or 5 different categories, but we've just put the top 2 here because they're the most profound, I suppose, in terms of what impact it will have on patients. So a Category 2 ambulance would be for someone who's had, for example, a suspected stroke, and it's the target for a patient calling an ambulance and being assigned a Category 2 on their rating scale would be that you'd have an ambulance with you within about 18 minutes. But at the moment, within England, the amount is, it's running at 47 minutes, 59 seconds. Now that is really terrible because a lot of the patients who fall within this category will have particular elements of their care which need to happen in a time-specific manner in order to care for this person properly. If there's a delay like that, you could be looking at missing out on a crucial window of opportunity to treat somebody. So these lengthy ambulance waiting times are not simply a case of people being bored or fed up or, you know, having a bit of pain. It can be the difference in life and death, and this is very, very serious. Could you move on to the next slide, please, Hannah? Thank you. So when we think about the crisis that is going on at the moment, one crucial element of this is the workforce. The NHS in England is missing almost 10% of its entire NHS workforce at the moment. It's a complicated situation involving not recruiting enough people, not training enough people, and then not supporting people. We've got lots of people leaving the NHS, moving abroad, changing career, retiring early because the situation is so stressful. We've also had repeated pledges to build the number of GPs that we have, and each of those pledges has fallen down because not enough effort has gone into the recruitment, training, and all of the above, you know, support and everything that we would need to increase our primary care workforce. Just a couple of statistics here. So BMA in Scotland have found that their consultant vacancy rate may be as high as 15.2%. And in Northern Ireland, more than half of all NHS consultant posts were not filled this year. So you can imagine what that does in terms of patients receiving attention within healthcare facilities. There simply are not enough staff at the moment, and the staff that we do have are under the most enormous pressure. I cannot tell you how much pressure these staff are under. We hear stories every day from NHS frontline doctors. Some of them are truly heartbreaking in terms of the pressure upon somebody and their feeling that they cannot step away from their service because they know what impact that will have on their colleagues. In fact, a couple of days ago, I heard about a doctor who was stabbed in a situation where there wasn't sufficient staff support on a ward. A patient with dementia was disturbed and stabbed a member of staff, and he didn't even take a single day off. He went home, had a few hours off that afternoon, and went back to work the next day because he was the only doctor available in that small hospital and didn't feel able to take any time off for his own recovery. So that is the sort of thing we are looking at right now when we're considering this situation. Could you move on to the next slide, please, Hannah? Okay, so all of that is terrible. And actually, when you think about that, you can feel extremely disheartened and hopeless and helpless. And I think a lot of people do. I think maybe that's one of the reasons that solutions aren't being found. We've really had to think about what could be done in the short term, what's practical and what's possible, because there are long-term solutions to this as well. We're not delivering this plan with the idea that this is going to solve everything in the long term. However, there are some things which the government could do right now, which would make a difference this winter. The biggest issue we have is the workforce, and the workforce need to be bolstered and supported in every single way they can. So I'm just going to take you through these 5 things quickly. So as we know, energy costs are rising across the board. There was a pledge from this government a couple of weeks ago that they were going to absorb additional energy costs in NHS workplaces. We weren't certain if this included GP workplaces, but someone with our network found out what was going on locally and said that this was going to include GP services, which is good because it means that it's not going to impact on the budgets locally, which would have impacted on patient services, if you see what I mean. Energy costs look like they are going to be supported. However, as we all know, things are very chaotic at the moment and we don't know what's going to be in the budget at the end of October. So we're waiting on tenterhooks to find out about the energy cost element of this plan. Number 2, enhance mental health support for NHS staff. What happened during the pandemic is that there was an enormous burden of trauma absorbed by NHS staff. We and others did a lot of campaigning about providing more mental health support for NHS staff. And in early 2021, the government announced that some mental health hubs were going to be set up around the UK to support staff. Now, they have met some of the need from NHS staff. However, the need at the moment is really sky high. People are waiting too long to access things like counselling support. And so that budget needs to be increased and more of these hubs need to be set up in order to support people who are going through enormous stress and pressure. Okay, so the next 3 on our list are probably easier in policy terms to implement, and will make a direct change to the number of staff who will be working in GP practices and in hospitals this winter if these things are put in place. We are asking for locum caps to be removed. Some of you may know all about locum caps, and I'm sorry if I'm repeating things that you already know. We do not think in the long term that temporary staff is a good solution for the NHS. It's not sustainable. It's not good for anyone, actually. It's not good for staff teams, and it's not good for the patients either. However, in the short term, we need to be able to pay people enough money for overtime that they will come in and work extra shifts. At the moment, we are hearing from lots of NHS staff members who are so tired and feel upset and isolated, and they haven't been supported, that they're not really willing to do an extra shift at the weekend or an extra night shift or an extra few hours here and there. They're just not doing it because they're preserving their own selves and preserving their free time. If you could remunerate people properly for their free time to come in and support the workforce during an incredibly pressured time, then that would really bolster our workforce. At the moment, these locum caps are a policy that came in 2016 when the locum fees were going up enormously and some NHS trusts were being put into debt as a result of them. This winter, those locum caps, which in real terms means a cap on the amount somebody can earn per hour for the extra work they're doing, they need to be removed. It just needs to be recognised that we're in an emergency situation and that we need to recruit in as many staff as we can to work extra hours to support the workforce, support the staff, support patients. And to allow this to happen, we need to ring fence a new budget for that. The NHS budget in general was increased until 24-25. There's been an awful lot said about that. In real terms, the government increased the NHS spending, but not enough to absorb these extra energy costs, and certainly not enough to absorb an extra amount to pay for locums this winter. So we need a new budget created for hospitals and for GP surgeries in order to employ people to work overtime. That's really important. The fourth thing on our list is about the Home Office. There are huge numbers of healthcare workers at the moment coming in from other countries to help support our workforce. They have been offered jobs, and many people have arrived in the country but are unable to start their work because of pieces of paper that they haven't been sent. There's 4 documents that you have to receive in order to start your job. Our presumption is that there is an administrative backlog that is so significant that that is the thing delaying these visas and other pieces of paper being sent to people. We've sent out FOI requests to every NHS trust asking what is happening, and I'll show you the figures for those in a minute. But there are thousands of people in this situation who need to start work and cannot do so because of paperwork. We need to sort that out. The Home Office needs to sort out its administrative processes urgently to get things moving and get people working. And finally, we need to reform the NHS pension tax regulations. They are pushing some doctors out of the workforce in an active way right now, in a way this is really significant and really scary. And I'm going to hand over in a minute so that one of our doctors can explain how this is affecting her hospital, which is a teaching hospital in central London. But I'm going to talk about a couple of other things first. Hannah, could you just come on to the next slide for me? Fab. So I've spoken about the energy costs. I actually don't want to focus on this slide too much because it's all a bit up in the air at the moment about what's going to go on regarding government support. So we don't know what's happening. And I think we'll probably find out more soon. Brilliant, Hannah, you can move on. This is just a slide to emphasise what I was already saying about mental health support. Doctors are just exhausted, and there's surveys that are being done, and they're just saying consistently that people are exhausted, they're thinking about leaving, and the situation is really, really dire at the moment. Hannah, could you move on? Yeah, I've already explained that, so let's flip past that as well. Fantastic. This was the thing I wanted to focus on. So there are, I think, 219 NHS trusts in England. We have heard back so far from 20 of them. And as you can see, this is the information we've managed to glean. So We've asked how many of your doctors are currently on a visa, and there's about 2,500. That's for about 10% of the total number of trusts. How many of your healthcare workers are currently in the process of applying for a first-time visa? 341. So if you extrapolated that, let's imagine this is 10%, there's maybe 3,500. There's also, you know, as you can see, hundreds of people applying to have their visas renewed or applying for indefinite leave to remain. So this is not an unusual situation. This is not a case of the Home Office losing or misplacing a couple of applications for visas. This is thousands of healthcare workers who are being stopped from entering the NHS workforce, and it needs to be addressed immediately. Could you move on, Hannah? Fab. So I'm going to hand over now to Megan. Megan is a consultant anaesthetist in London, and she also has a background as a barrister. So she works for EveryDoctor in that capacity as well. But Megan is incredibly worried about what's going to happen this winter because of the pension situation. So Meg, would you mind just explaining what's going on?
Absolutely, Julia. Yeah, I will do my very best to do that. I'm quite glad that I'm up first here, because pensions are not the sexiest topic, but they're really, really important. And so I am one of those doctors who I will be dropping my hours. And if I don't do that, I'm going to face a big tax bill. And essentially the headline here is that I'm willing to do a lot, but I'm not willing to pay to come to work. And that effectively is what the pension tax regulations are doing to doctors. I'm going to drop probably 10 hours of my working week. I have a colleague, currently I work at Guy's and St Thomas's, so bang opposite you guys at Westminster. So if anyone wants a bit more detail, do feel free to give me a call. I'm happy to pop over the river and chat to you. I've got a colleague who is going to be dropping nearly 20 hours. And the reason for this is because of the just general pension tax rules. They're not specific to doctors. They cover every sort of public sector pension. Basically, we pay tax on pension growth. So over a certain, my pension can grow in value by a certain amount per year, and then if it goes over that amount, I pay tax on it. And so that those amounts, I don't want to get into the minutiae, but it's £40,000 of growth for a year, and over my lifetime, the lifetime of my pension, it's now just over £1 million. If it grows bigger than that, I have to pay tax on it. The £40,000 amount has been whittled away at since 2010. So in 2010, it was £250,000. Same with the lifetime allowance. In 2010, it was £1.8 million. That 250 is now 40,000, and 1.8 million is just over $1 million. So massive drops in those thresholds. That's important because pension growth, and again, you all glaze over, but it's basically a function of an equation which is sort of decided by all of the money people, and the equation is basically every element of that equation is not something that I can control as a doctor. The only bit of it that I can control is my salary. So it's got a couple of just fudging numbers in there. It also includes the number of years service. I can't control that unless I leave completely. And it also includes inflation. And now obviously where inflation, was 1 or 2%, now we're 10 point something percent and heading up right now. And so what that means is that without changing my hours, without working any more or any less, or at least without working anymore, my pension pot has grown out of my control completely. And if I work the same hours now as I worked last year, I'm going to end up being hit with a tax bill of somewhere between £10,000 and £20,000, i.e. I'm going to be paying to come to work. The only bit in this equation that I can control is my salary or my years of service. So I can do one of two things. I can reduce my hours and reduce my salary so that doesn't get thrown into the equation and I don't exceed the limit. That means that I get some time for myself. So I don't get a big tax bill and I get some time. I earn a bit less money, but overall, because I'm not paying the tax bill, I'm actually better off. All the rest of it, I can't control unless I choose to leave completely. And lots of doctors are doing that, particularly very senior doctors who are retiring early. So completely stop the number of years of service now, leave, retire, and then you don't trigger either the annual allowance penalty or the lifetime allowance penalty. And for those really senior doctors, it's the lifetime allowance one as well. And the rate of tax on that is something is up to 55%. So they're leaving, they're taking early retirement, they're going because otherwise they're going to be paying to come to work. And what I would say is that I challenge anyone to show me someone who is happy to pay to come to work. I think doctors, we all do way more than we're paid for, and most of us do that sort of, I wouldn't say happily, but we do it because it's a necessity and we accept that it's part of the job. And the NHS has always run on a lot of goodwill. So we do stuff for free, but I am not paying to come to work. I'm not willing to do that. I really care about my patients, but I am not willing to pay to come to work. And the only way I can avoid it is reduce my hours. So from probably after Christmas, I will be cutting my hours by 10 hours a week, so going down to 75%. As I said, I've got a colleague who's going down by nearly 20 hours. This is happening all across my hospital, across every specialty, up and down the country, whether it's GPs, whether it's hospital consultants. And in terms of getting those waiting lists down, the people that you need around are people like me. You need anaesthetists, you need surgeons, you need cardiologists, you need gastroenterologists. And we have our level of seniority, a level of expertise, and an ability to get through a lot of this stuff quickly, and you're losing us. And I suspect that a lot of people who reduce those hours and then see what the difference is in their own quality of life, their personal life, I don't think you'll get them back. I think we'll all say, do you know what, I'll take a slight financial hit, I'll earn a little bit less, I'm not coming back. So something needs to be done now, because not only do you need me not to be working less than full time, really, to get through any of these waiting lists, you need me to be working more than full time, and that's a definite disincentive. So I hope that that's made sense. If it hasn't, then please ask some questions in the chat. And as I said, I'm right across the river from you guys. I'm very happy to meet with anyone who wants a bit more information on this point or on any of the other points covered here today, or any other points to do with the NHS. I work full time as a consultant anaesthetist, so I'm pretty good for finger on the pulse of what's going on. Thanks very much.
Thanks, Meg. Thank you very much for explaining that. Okay, we are going to hand over now to, is it Hannah? Sorry, is it Emily? Emily, brilliant. Emily is one of our GP members who works in Liverpool. Can you explain what the situation is like at the moment in primary care? Thanks, Emily.
Oh, thanks, Julia. So I'm going to give you a bit of a whistle-stop tour because there's a lot to cover, but I don't want to bore you. So to put it very bluntly, general practice is pretty much dead in the water. We've been briefing for over a year now about the direction of travel, but unfortunately nothing's really been done to remedy this. And what's really frustrating is that it's actually your constituents who are paying the price for this. As Julia said, people are dying needlessly due to the parlous state of the NHS, and this winter is all set to be beyond all reckoning. It's been made worse by the collapse of social care and by the economic injustices and cruelties being inflicted on the most vulnerable of society. So even if we take immediate action today, I think we have to be really clear about the fact that what we're talking about is minimising the numbers of people who will die. We're not talking about stopping them dying, and I think that's a pretty depressing place to be in. So here's why we are where we are in general practice. Years of chronic underfunding and under-resourcing by successive governments, not enough general practitioners, as Julia said. What people don't seem to understand when they talk about bringing in other clinicians who are great people, but people like physicians associates, advanced clinical practitioners, paramedics, pharmacists, what people don't understand is most of them remain under general practitioner supervision. So you need a GP to sign their prescriptions, take legal responsibility for their work. A lot of them are independent practitioners, and even if they are, they can't do all the things that GPs can do. So that leaves the few of us who are left picking up all those pieces. You know, again, as Julia says, shortage has been recognised for years, but it wouldn't matter if you set the entire department of health to crocheting GPs tomorrow. They aren't going to get enough because it takes years to train a GP. So we're looking at short-term solutions, but actually a longer-term solution is needed, and very urgently. The pensions debacle, as Meg has said, has led to people leaving a lot earlier than planned. Working conditions, I think, is a big one, and that is leading to people going to other countries for a better work-life balance, people going to become salaried GPs rather than partners and managing the practices because they can cap their workload, people going to be locums, better money, better work-life balance, control over what you will and won't do, capped workload, and of course market forces drive this, which means that they can pretty much name their price, and unlike trusts, we can't cap locum costs. So even when we can get them, actually it's becoming the case that we can't afford them. in general practice because we can't keep the lights on as well. This is leading to a collapse of practices because nobody wants to be a partner, nobody wants to manage because they don't want to pick up the pieces. And this means that practices are being bought up by private companies whose bottom line is to give their shareholders a good return. It's not to give their patients good quality care. And this is another huge issue that general practice is facing. The mental health crisis is very real and hugely problematic. There is a lot of burnout now, and colleagues, and indeed myself, who I would qualify as pretty tough people, actually ending up in a real mess and having to have time off. That puts more pressure on the colleagues that are left, which means they're more likely to burn out, which means they need time off, and it just becomes a whole horrible, vicious circle. And there have been some suicides, some of which have made front page news. And that is because doctors are struggling, and not just GPs, but they're struggling with moral injury, which is kind of what we use, a term we use to describe where, you know, we went into medicine because we want to save lives, because we want to help people, and actually we're actively being prevented by doing that by policy. And the situation we find ourselves in, and that's hugely, hugely psychologically damaging. The increased workload is due to a number of things. We have a massively aging population. They live longer with very complicated conditions, and that's great that we're keeping them alive, but it comes with its own sets of issues, one of which is the number of times they need to see a GP. So the global sum, which is part of how we're paid in general practice, that expects that people will visit us about 4 times a year, which is right for the under 65s. Once you get over 65, it's about 12 times a year that they will come and see you on average. So you can see already there's a huge mismatch between expectation and reality. The difficulties in secondary care through no fault of my secondary care colleagues. Traditionally, the solution has been to move things out into general practice like diabetes care, long-term condition care, respiratory, etc. Never come with any resource, and actually we just can't absorb anything more. Current long waits, patients are still symptomatic. Where do they come? Well, to us. Collapse in social care, people don't know what to do, where to turn, where do they come? General practice, and patients are treating us like an emergency and urgent care service, and that's not what we're here for. We're here to add value by managing complex long-term illnesses, and there's just few of us to do it. So I work 3 days a week nominally. So according to the BMA, that should be 8 hours 20 a day, or 25 hours for the 3 days for a week. Pre-COVID, that was on average about 36, which most people would consider to be full-time or nearly full-time. And during COVID, they were 65-hour weeks. And as you can probably guess, that's not sustainable, and it makes people very unwell. There are also the media campaigns that we have had to endure actively against us, backed by senior officials like the Secretary of State for Health, the head of NHS England, who mind-bogglingly remains in post. And this damages morale, is basically incitement to hatred, and it leads to abuse of ourselves and our staff by patients who feel vindicated because this is what they've seen senior officials talking about, and it leads to a breakdown of the doctor-patient relationship, which means that we can't offer patients really good care because there's a break there in the relationship. And even now we're still being undermined with this, oh, don't worry, we'll just hand out antibiotics, oh, don't worry, we'll just get SAS doctors in to do this, oh, don't worry, as if we're not consultants or specialists and not deserving of recognition as such. I mean, I could go on, but you'll be pleased to know I won't. There seems to be this very bizarre belief that GPs who couldn't organise themselves to fend off successive horrendous contractual changes have somehow met under the cover of night and decided to be lazy. The public desperately need educating. The media need to start reporting on the realities and asking some questions about why this is happening, because basically GPs just sunk. We are trying to survive now and trying to keep as many of our patients alive as we possibly can during what's set to be a really harrowing winter. So we need you guys to start mobilising. We need you to start working with us both on the kind of the short-term solutions that we've put forward, but actually also the long-term solutions, because I can bleat on about how rubbish it is to be a GP and how miserable I am, but the bottom line is that it's your constituents who are dying, and the window of opportunity for us to do something about that is closing really rapidly. So please, I urge you to engage with us and let's do something about it.
Thanks, Emily. That's really powerful. Okay. I mean, even I feel exhausted by us, to be really honest. It's a bit intense, isn't it? It feels like we meet with you guys. Quite a lot of you are familiar to us, obviously, and have been through the pandemic. And every single time we're sort of moaning about something, but things truly are getting worse and worse. And sometimes it's unbelievable to us that it just continues to get worse and no action is being taken. The moral injury that Emily describes is very real. Okay, I'm going to hand over now to Dr Maria Corretge, who is a hospital consultant up in Scotland, and she's going to explain what things are like where she's working at the moment. Maria, can you take over?
Hello. Yeah, I'm not sure if you can see me. I just wanted to say, sorry, I'm a bit nervous. That I know health is devolved in Scotland, but these problems are universal. They're seen across all the UK nations. It's true that we're exhausted because none of the relief that we had during the pandemic has been forthgoing. I think people thought, oh, the pandemic is over and now we're fine, but we're not. You know, we still need the support of, you know, extra support for mental health problems. We had the relief of not having to do our appraisal, which is a process which in general, you know, quite a few senior doctors are pretty cynical about. A lot of money gets spent on it and it doesn't add value to what is needed right now, which is face-to-face care of really vulnerable patients. And that has continued now. We used to have extra help with complaints and things like that. That's disappeared. So everything has gone on as normal when in front of our eyes things are changing. Patients are waiting for so long in hospital trolleys, in A&E. That's a situation that's new to me. When I started working as a consultant 9 years ago, I didn't see that. And I'm seeing that all the time. It's heartbreaking because we cannot provide good quality care. We cannot provide sometimes basic care. That is a reality for a lot of our patients. These are basic things and we're failing them. Sometimes not even, you know, through lack of staff. You know, we can put the staff, but if you're going to have a patient waiting in A&E for hours and hours, so the back door is really important. And that is something that Coffee has addressed in her plan to fix the back door. It has huge ramifications. It won't be an easy task, but the 5 points we've given you are easy. We can cap the pension things. I'm one of the mugs that paid to go to work last year, will pay again this week. And I have an envelope to send to relieve me of my pension, to come out of the pension in the NHS. And that will mean that if something happens to me, my family won't get a pension. My children will not be protected. And I have to do that because I still have to work full time because I know my colleagues need me. So I'm putting myself in a position of vulnerability to help out. And it's not fair. And I think we're all sick and tired of it. All across the nations. It's not just in Scotland, it happens in England. And I think we've come to a point, I'm somebody that did not want to go into medical politics, but I'm here talking to you because I don't want the NHS to fall by the wayside. And with all the, you know, many different directions in which you're pulled, these will be visible. Our mortality rates will go up. Our numbers are not going to be good. We'll be the sick man of Europe 10 times over again. We have to do something. We have to do something. We have to do these 5 things at the very least. So thank you for listening.
Thank you, Maria, for explaining that. It's really difficult because I think you can hear in Maria's voice how upsetting all of this is. This isn't a natural arena for doctors to be speaking in. Actually, none of us. You know, none of us feel completely comfortable talking about these things, and we feel really uncomfortable talking about patients being in danger. You know, when you go to medical school and you learn how to be a doctor, one of your most important roles actually is to provide reassurance to patients about how safe they will be in your care. and that we will do everything possible to keep people safe, and coming and speaking, you know, this event's being live streamed on Facebook, and telling people we don't feel that they're safe, and we're worried because people are dying unnecessarily and it's going to get worse. I mean, that's terrifying. We know that we're terrifying people, and we don't want to be doing that. So that's why we're here today, guys. I had hoped that a fourth doctor could join this morning, called Mohammed, who's a doctor who's on a visa and has been treated terribly by the Home Office. But I'm just checking, and I think he's probably been pulled away for a clinical reason because he was in clinic this morning. So I'm terribly sorry about that, but I will quickly summarise what is going on for Mohammed. Mohammed is an NHS doctor who was waiting many months for the Home Office to give him a repeat visa. So he was already in the country working in one of our hospitals. And when you're waiting for a visa to be renewed, you're not allowed to leave the country. The understanding is that it'll only take a few weeks, and so people sort of absorb that inconvenience. But for Mohammed, it lasted for months and months, and he's not had an explanation as to why. He has finally just received his repeat visa from the Home Office, but it took about 6 months, and he wasn't able to travel abroad during that time. His example, compared to many that I've heard, is actually quite minor. I've heard from people waiting for documentation who haven't been able to enrol their children in school. I've heard from one person who was almost made homeless because had been offered a job in the UK and was expecting to start work, and then the work didn't start because her paperwork didn't start, and she was in a really terrifying situation. All of these things are so important, and we're very aware that there are lots of other things going on in society at the moment which are also important. But I mean, I suppose in response to that, I would question what is more important than patients who are going to die. You know, this is really, really stark. We're going to stop talking now, and we are handing over to anybody who has any questions for us. I'm having a quick look in the chat box now, and there's none in there at the moment. Does anybody have any questions for us? I mean, given that there's none written down, I'd be very happy for people to just take their microphones off mute and ask directly, if you like. Okay, we've silenced everybody. I'm terribly sorry.
I'm terrified of everyone, Julia.
Yeah, clearly. Okay, well, we'll wrap up then if nobody has questions for us. Hopefully that's because we've explained the situation in a clear way. So what we are hoping to do now with yourselves and with your colleagues is to work together to find ways to demand that these 5 things happen. Hannah, would you mind just popping that list again of the 5 asks we have for the government, just so I can run through them really quick? So just to recap, these are the 5 things this winter which will make things safer for patients. We need the government to pledge to absorb additional energy costs for NHS workplaces. We need them to pledge to enhance the mental health support for NHS staff. We need them to remove the locum caps and ring fence a new budget for NHS locum staff, which will mean that NHS staff can work extra overtime and be properly paid for it. We need them to address the administrative problems in the Home Office which are preventing NHS staff from starting their jobs and helping the workforce. And finally, we need immediately for the pension rules to change. These are pushing senior doctors out of our workforce in a very real way right now. And I'm receiving emails from consultants who are saying, exactly as Megan has told you, I'm dropping my hours. We do not want our most senior clinicians dropping their hours this winter. We want them to do their normal hours or maybe even do extra, but we need to support people. I don't shy away at all from recognising NHS staff as workers. We need to treat them as workers, and somehow we've lost sight of that. Okay, so if anybody would like to pledge to work with us on these 5 things, please send us an email on campaigns@everydoctor.org.uk and just say, yes, I pledge. That'd be absolutely fantastic. We would love that. We will tell our network of 400,000 people that you are working with us this winter. We also would love to help you to structure questions to Parliament or to a particular minister. We would love to help you write letters. We would love to help you write speeches. Whatever it is that you need from us, we will help you. But please just let us know what you need us to do. We talk to an enormous number of people, and they are watching what parliamentarians are doing right now. They want you guys to step up, and I know that there are enormous pressures on you, but please step up. If you step up, you will save lives. It is really that stark. We cannot ignore this situation any longer. Thank you ever so much for your time this morning. We really, really appreciate it. And we hope that we'll hear from you soon. Thank you.